It is a huge honor for me today to be podcast interviewing Rohan Wijey all the way from Australia, and it's already tomorrow there. It's 4:40 p.m. It's 5 p.m. here in the United States, and it's already 9:30 a.m. tomorrow morning. So my first question to you is, how did the market open tomorrow in the New York Stock Exchange?
I'm not sure, but yeah, time traveling is one of my many skills.
You're a day ahead of me in time, and you're light years ahead of me in myofunctional research. Dr. Rohan Wijey is the clinical director and senior lecturer of the Myofunctional Research, MRC, and CEO of the Myobrace Pre-Orthodontic Centers. His myofunctional journey began in 2007 by working under the founder and CEO of MRC, and he has since lectured across 5 continents and has published in orthodontic and pediatric journals around the world. During his time at MRC, he has seen the worldwide acceptance of myofunctional orthodontics grow rapidly to the point where the Myobrace and Trainer Systems are now the most widely used early intervention orthodontic treatments in the world. Dr. Wijey is also a qualified myofunctional therapist, having completed training programs in the USA, Brazil, and Australia. Despite his heavy lecturing schedule, he remains very much involved in clinical practice, dividing his time between the 4 Myobrace centers owned and operated by MRC in Australia. Not to start off too crazy, but I'm just afraid there's a lot of homies listening to you right now that aren't really sure what myofunctional means. What do you mean by myofunctional versus traditional orthodontics?
Yeah, no, that's a valid question. I guess, first of all, we don't feel as if we're doing myofunctional orthodontics per se. Obviously, it's on a lot of our advertising and educational paraphernalia. We believe we're doing myofunctional treatment, and one of the happy benefits of that myofunctional treatment is straighter teeth, development of the arches, development of the craniofacial complex, etc. So yes, orthodontics is a part of what we do, and the way we do that is by training the muscular causes or retraining the muscular causes of malocclusion. But it's so much more than that.
You know, some of the most mind-blowing stuff I ever read on orthodontics in general actually came from your country, Australia, way back in the day. But I want to start with this question. You know, a lot of people that study hominid fossils, you know, that say that, you know, 400 years ago to 2 million years ago, they don't see any of these malocclusions, and they don't see any of this stuff, and now it's everywhere. And so before we talk about treating it, why do you think that every time they find a human 400 years, I mean, that's not, I mean, Rome was just 2,000 years ago. Why in the last 400 years is this all around the world?
Sure. Well, look, the obvious thing to say, first of all, is that it's not an evolutionary thing if it just happened in 400 years, because for an evolutionary change of this magnitude to happen, for an affliction to go from 2% prevalence to 90% prevalence, you'd need hundreds of thousands of years, if not millions of years, for that to manifest. So we know it's some sort of environmental factor or factors that's causing it. And we think the environmental factor that has been across the board around the world is diet. That's the main thing. And we know that our diets in modern times are extremely different to our diets in primitive times. And what role does diet have to play exactly? Well, there's 2 factors. First of all, the texture of the diet. So the harder the diet, the better trained your muscles of mastication are, which means your muscles, including the tongue, behave a lot better. The softer the diet, the less your muscles of mastication have to work. And that means you start to recruit your facial muscles during function. And that tends to hold back proper craniofacial development. But then there's also the nutritional side of things as well.
Well, you know, it's funny. I mean, you see all the baby food; it's just jars of mush, and I mean, there's just rows of it. You know, 20 feet long at the grocery store, just jars of every kind of mush there is. The baby's basically just eating something like applesauce.
No, look, you're absolutely right. I mean, and it's not just the texture of the diet; it's also the fact that we're eating a lot more refined sugars now. Obviously, caries is one of the sequelae from that, but it's also mouth breathing. Our diets these days are intrinsically inflammatory to the human body. And when we have something that's inflammatory to the human body, we're much more likely to be mouth breathers.
God, I love listening to your accent. I could listen to an Australian all day long. It is so fun to listen to. Why do you say that orthodontics needs an overhaul?
Why do I say orthodontics needs an overhaul? Look, I think orthodontics has moved away from being a health science, and it's more to do with cosmetics now. And that's not such a bad thing. Cosmetics definitely has its place. But I think orthodontics needs to go beyond just cosmetics because it has the potential to do so. It has the potential to do so much more than what it's doing now.
And if one of our listeners, your website is myoresearch.com. What are they going to find if they go to myoresearch.com? How do the people listening to you right now learn more about myofunctional orthodontics? Sure.
So for professionals, professionals aren't limited to orthodontists and dentists and pediatric dentists who use our appliance systems. Also, ENT specialists are starting to use our OSA range, and chiropractors are starting to use our TMJ appliance range as well. So all professionals, myoresearch.com is the website to go to. There's also information there about our training programs. But for the general public, we have myobrace.com. Now, the Myobrace system is our myofunctional orthodontic system. We've also got myosa.com, which is basically our SDB and OSA range. So myobrace.com and myosa.com for the general public.
And so so your courses to learn myofunctional research is on myoresearch.com?
That's right.
Yeah. And what kind of curriculum do you have? I mean, is it how long is the course? How do they learn more about this?
Yeah. Sure. So various ways of learning. I mean, to be honest, we're in 100 countries now, and a lot of the practitioners who use our products and our ranges, they've never been to a training course before. And that's because the biggest department in our company is our production department, and our educational department. So the websites are fully equipped with info, but we do highly recommend coming to a course. And we have courses going throughout the year in most countries around the world. And we have beginners courses, we have advanced courses, we have courses that have more of a slant on TMD and OSA, etc. But the best thing to start with is to come to a beginner's course. Normally the courses, they can range anywhere between 2 and 7 days, depending on what the course is.
You know, on Dental Town, we have over 250,000 on the PC, but we put the app on. That's over 50,000 now, and we put 360 1-hour courses on there. They've been viewed over 600,000 times. You should put some introduction courses on there. You should put hour course up there, or 2-hour course, whatever, and then at the end say you want to learn more. Go to your website or go to your hands-on course. I think it'd be great information for the townies on Dental Town and great marketing for you.
Yeah, I'd be happy to, for sure.
Yeah, I would love that. Yeah. So how does myofunctional have an impact on malocclusion?
Okay. So look, known for a long time, I'm sure even when you were at dental school, Howard, you would have learnt about the Moss's functional matrix theory, et cetera. So we've known for a long time that muscles do influence the craniofacial development. The way that happens is basically what's ideal is you breathing through your nose, like what you're doing right now. Now, Howard, is your tongue in your palate right now? Where is your tongue right now?
Yeah.
Yeah, good. Yeah. And that's why you've got a decent maxilla. Do you have a decent maxilla?
Do I have what?
A decent maxilla, upper jaw.
Do I have a deep maxilla? A decent maxilla?
Decent.
Well, yeah. No woman has ever told me I had a decent anything, but I'm going to go with yes.
What about man? Okay, all right. So, look, I think the concepts are pretty well accepted that if you breathe through your nose, you have your tongue in the right spot, your maxilla develops properly, not only transversely, but you get proper AP displacement of the maxilla away from the airway. And a lot of research now shows that if your tongue drops away from the palate, you start to recruit your muscles of facial expression, to swallow and to function, and that can limit your craniofacial development, in particular the mandible, with what we call a reverse swallow, when you swallow with movement under your lower lip.
Now, where I'm seeing you now, obviously it looks like a pediatric dental center, right?
Yeah. Well, I mean, the ideal age to intervene with this kind of stuff is between 5 and 15 years of age. That's because, by age 4, 60% of the craniofacial complex has been achieved. By age 12, I think it's 80 or 90%. So, look, the pediatric population is where we like to concentrate our efforts. So what you're seeing behind us, this is not actually a functioning clinic. This is one of our training centres here in Australia. But this is what we have in all of our clinics around the world. It's called our activity centre. And this is where we do our myofunctional therapy. And for a lot of your listeners who don't know what that is, it's basically exercises to retrain the way the kid's tongue is behaving, the lips and cheeks are behaving, et cetera, et cetera.
And go back to the stats. You said by age 12, 90% was formed, but what was the first stat you said?
Yeah. By age 4, 60% of the facial skeleton has achieved its adult proportion, which is mind-boggling to me. But it shows you how important early intervention is. And I'm not talking about straightening teeth. I'm talking about the health of these kids, especially from a sleep apnea perspective.
I think most general dentists listening to you right now think of early interceptors. The only tool in their toolbox for that is just a rapid palatal expander, trying to widen the maxilla. Sure. But you're talking about more tools than that. You're actually talking about teaching them different exercises. Talk about that.
Yeah. Sure. Well, look, the first thing to say is, I mean, early treatment's been done, and early treatment's been roundly discredited. Not only in the whole orthodontic diaspora and pediatric diaspora, but also in the research. I mean, in 2007, there was a Cochrane review that came out saying that early treatment, when you're translating the mandible, doesn't achieve much in the long term. And it's absolutely true. I'm the first one to say that traditional early treatment doesn't work. Things relapse. And one of your great American orthodontists, Graeber, back in 1963, he came out, it's my favorite article ever, Graeber 1963. He says the guys who are just doing traditional orthodontics, who are just using fixed appliances, have been guilty of ignoring the role of muscles, but so have the guys who have been using functional appliances and intervening early. It's the same with fixed appliances. It's the same with upper acrylic expanders. It's the same with RMEs. If you modify the facial skeleton, but the surrounding soft tissues aren't in harmony with your changes, you are going to get relapse. And there's no point in doing early intervention if you're not controlling those causative factors. So we need to go beyond just expansion. We need to retrain those causative factors. And I'm also, Howard, I want to make this clear, we are not against braces. I mean, braces are still the best way to align teeth. No doubt about that, conversation over. There's still a place for postural appliances, still a place for functional appliances. There's still a place for orthognathic surgery in our armory. You know, we're not dogmatic about any singular approach. We think we need everything. But what we are dogmatic about is we say we need to go beyond just mechanical. We also need some sort of biological approach, because we're not dealing with just mechanics here. We're not dealing with just teeth that are divorced from the mouth and the body. We're dealing with a biological complex that deserves a biological solution.
Describe what these are. You bring kids in for what, a half an hour, and you go through different exercises?
Well, look, traditional myofunctional therapy, I mean, if we're trying to retrain the muscles, traditionally with myofunctional therapy, you would do that. You'd bring them in for half an hour, often once a week. Often it's an 8-week program. Nowadays they're doing it for longer, up to 12 months. What we've realized, first of all, is I do not blame any traditional orthodontist for thinking that myofunctional therapy is complete crap, because it's been tried and it's failed. It has completely failed. I lectured a couple of times at UNLV, the University of Nevada, Las Vegas, last year to the ortho faculty. One of the professors came up to me and said, and he was really old, he was in his late 80s, I think. And he said, look, I learnt about all this stuff when I was in ortho school back in the 1970s. A myofunctional therapist came in and taught me the 8-week program, but how do I implement it? And that's the key thing. I mean, it's all well and good to have sound theory behind you, but an approach or a technique is only as good as its practical implementation. Now, with an orthodontist, I mean, usually, as you know, look, the appointments are about 3 to 5 minutes, if we're being generous. With a myofunctional therapy appointment, as you said, it's about half an hour. What orthodontist is going to spend half an hour teaching a kid where to put their tongue when they could be seeing at least 6 patients during that time, not having to talk to the kid? I mean, I know which one I'd choose. So look, myofunctional therapy has got some sound philosophies behind it, but it has been a completely unpractical and unpragmatic approach. So look, we recognize that problem, and we're delivering myofunctional therapy in a different way. And the first way is we deliver it in the form of an appliance. So this is what one of our Myobraces looks like. We've got quite a few. Have you heard of the Frankel appliance before, Howard?
Yes.
Yeah. So the Frankel was the first ever true myofunctional appliance, and it was invented in communist East Germany. It looked a bit like a communist torture device as well. So it had kind of acrylic and wire everywhere, stretched the lips and cheeks away. The original design had some tongue prongs down the bottom to prick the tongue up into the palate. It worked quite well, but I mean, no kid in the 21st century, especially in America or Australia, is going to use a Frankel and keep all their friends, basically. You know, they have to use it for 22 hours in the day, etc. So we've incorporated some of the basic tenets of the Frankel into this appliance. And by the way, all of this was invented by Dr. Chris Farrell here in Australia. And it's got what we call the Frankel cage here, which stretches the lips and cheeks away. And it's also, instead of the negative reinforcement of those tongue spurs, it's got this tongue tag that sits just behind the upper central teeth. And that's where the tip of the tongue should be sitting at rest, like where your tongue is sitting. So it trains the tongue to sit in the right spot, retrains the muscles of facial expression. And that's how we get our changes. And that's the most effective way to deliver myofunctional therapy to a patient. But we also supplement it with our program of exercises. So behind me, what you see here, as I said, is our activity center. On the screens, we have our app playing. So as you probably know, it's not really feasible for kids to sit in front of an older practitioner with that older practitioner telling them what to do with their tongue for half an hour. I mean, the kids don't enjoy it. I mean, practitioners would probably enjoy it even less. So what we've done is we've put the videos of what they have to do with their exercises on an interactive app. And we've got our own in-house 3D animators that have created all these animations of their exercises. There's a multiple choice questionnaire at the end of each video, and they have to fill out this quiz. And we as the practitioners, we get feedback as to how well they did on that quiz. So we know exactly at what level of understanding they're at. And do you have Snapchat, Howard? Bit of a weird question. Do you have Snapchat?
I have it on my phone. I've never done it.
Yeah.
I have 4 boys. I think they've tried it.
Right. Well, you're not admitting to it anyway. But with Snapchat, kids are delivering information in 3 seconds. I mean, they're not going to sit through half an hour. Information is being transmitted so quickly. We need to move with the times. It's not feasible anymore to deliver education at a kid's level that takes half an hour. We need to be delivering the information within seconds, and that's what we're doing. And that's why we're seeing a lot more compliance than what traditional myofunctional therapists are doing. The problem is,
I read a paper a couple of months ago that said that a child can only retain for 12 minutes, and if they're on caffeine, it's only 6 minutes at an increment.
Oh, that's interesting.
And then anything over 6 minutes, if they're on caffeine or 12 minutes period, they're daydreaming about something else. They're not even listening to you.
That makes sense. That makes sense. So, I mean, the way our flow works is they're in the activity center here, and our staff actually go through the activities with them. They're only chairside with a doctor for about 5 to 10 minutes, maximum 10 minutes, usually about 5. Then they're back out to the activity center to go through more activities afterwards. So most of the time is spent out here, about 80% of the time. And kids respond much better to education when it's delivered outside of the dental setting. You know, as soon as they cross the white line of the operatory, immediately they shut off. They're not listening to what you're saying. They're nervous. So we want to deliver as much as possible out here. We just do little cursory checks in the operatories, and we're finding that we're getting through to the kids a lot better, and we're getting much better results as well.
Yeah, I really hope you build an online C course. I think this would be so cool. I think a lot of people that are listening to you right now, this is all new to them. I think myofunctional is very new. And I have to be honest with you, there's a lot of conservative, I mean, there's 211,000 dentists in the United States, and a lot of them are older, conservative, and they might think myofunctional is some weird holistic thing. I mean,
that's exactly what I thought before. Well, yeah.
Yeah. So what would you say to a conservative dentist listening to you say myofunctional? That's some young hippie
I'm glad you asked.
Holistic thing.
Yeah. I'm glad you asked, and traditionally it has been. They're absolutely right. And I was as skeptical. I'm probably the most cynical person I know. And you know, my wife began to work for the company before I did, and I told her it's complete BS. Don't listen to Dr. Farrell. I read the research then, and this was when I was back in third year dental school. I read the research on class 3 malocclusions. I just got a subscription to the AJODO. I read everything there was to read, and I read that muscles have a huge impact on it. The relapse rates with class 3 surgery, mandibular setback surgery, Prophet did a big systematic review in 2007, and he said that 67% have moderate relapse within 12 months, and 20% have a highly significant change within 12 months with mandibular setback surgery. And the principal factor in relapse, the research is pointing to the muscular environment not being changed as well. Muscles will always win out over the bone. So I read all of this, and I guess just like with any great revolution, they're always born out of anger. And I felt angry when I read all this, and it was at odds with what I was being taught in dental school. And I guess even that research, reading that research didn't convince me. I needed to see it working in my own hands to be convinced, and that's what I did. It was only really 3 months or 4 months after I started my first cases that I was truly convinced. The reason why I undertook the treatment at first was that I knew the worst that I could do was nothing. I mean, there's no side effects from this, which is more than you can say about anything else we do in dentistry and orthodontics. I thought the worst that can happen is nothing. Let's give it a shot. And I honestly think that every single kid around the world needs to have some sort of myofunctional evaluation. And I'm not talking about a teeth perspective. Yes, most of the practitioners who use our ranges are concerned about misalignment. And yes, it's been proven for 25 years to solve the problem of malocclusion, but I don't care about the teeth. I care more about displacing the maxilla and the mandible forwards for that airway. I mean, that's much more important than teeth.
So tell my homies, what's the prevalence of class 3 in, say, Japan versus Australia?
That's a good question. Now, we're programmed to think that East Asian populations have a much higher prevalence. I think in Japan, it's actually 3 to 5%. I'm looking at this research only a few weeks ago. 3 to 5% in Japan, 1.75% in China. It's not a huge significant difference. And the research shows really that every single class 3 malocclusion begins as a deficient maxilla. Yes, there comes a point when the mandible is taken off too far. The only option is surgery. But the research shows that, yes, you can do surgery, but unless you control the posture of that tongue and the functioning of the muscles, surgery is going to relapse as well.
That is amazing.
But it's crazy, isn't it? Yeah.
That is so
and look,
amazing.
We've known about this for a long time. And this is not controversial either, Howard. I mean, yes, myofunctional therapy as a treatment is very controversial still, especially in Anglo countries. Now, our biggest markets around the world are continental Europe and South America. It's really the Anglo, the English-speaking countries where it's a bit controversial. The funny thing is we're an Australian company, but Australia and New Zealand are our smallest markets. They're growing very fast, but America's actually, last year in America alone, we grew by 51%. It's been huge in America.
But
and
you know what? I noticed that, I've lectured in 50 countries. American dentists don't realize how resistant they are to change. I see so much more open-minded thinking in Europe and Brazil than America. I mean, do you think it's just the culture of the country, or why or even Australia? I mean, why do you think Australia and New Zealand is your smallest market?
To be honest, I think Australia and New Zealand are the most cynical countries in the world. I think America is a lot more progressive than Australia and New Zealand because I think we've been left with the legacy of that British colonial rule where, I mean, British people, tend to be a little bit conservative, a little bit cynical, which is not a bad thing, but they're a little bit slow on the uptake. I think Americans, what we've noticed, especially with our push in North America, we've noticed that if you tell Americans it's a good idea and they can make money out of it and it works, then they'll do it. I mean, it's a no-brainer. I mean, the great thing about Americans is that they're pragmatic. If it works, it makes some money.
Well, speaking of America, they say you never should ever talk about religion, sex, politics, and violence, but you mentioned, you dropped the bomb that the Franco
They're all
appliance,
my favorite topics.
You dropped the bomb that the Franco appliance was made in East Germany and it looked like a torture device. Yeah. Well, between East and West Germany was a wall. What do you think of the talk about building a wall between the United States and Mexico? Well, how does that sound like to your cynical mind in Australia?
Right. Well. First of all, unfortunately, I don't speak for all of Australia, but probably most of Australia. We love American politics. It's so much more exciting than Australian politics. Now, we just had our US summit in our facility in California. And so it was a 7-day summit. And I had a little segment on Donald Trump. And I spoke about how Donald Trump I think the Boston, a newspaper in Boston did an analysis of all these presidential candidates' level of language. And Trump came in at a 4th grade level with his level of language. But I said, don't knock him, because that simple and simplistic language is what's cutting through to the electorate. I mean, he defeated 16 seasoned political campaigners to get a nomination of a major political party. Don't knock him, because simple language works, and that's how we should be communicating with our patients. So I tied it in that way. It was kind of a backhanded compliment to Trump. But at the risk of alienating a lot of our customers, most of Australia think Trump is hilarious.
Yeah, I just can't believe that growing up with the Berlin Wall, that anybody in their right mind would be wanting to build a damn wall.
Well, they just tunnel under the wall anyway. It needs to be a subterranean wall. It needs to be a subterranean wall. They'll just tunnel under it.
I mean, I've been to the Berlin Wall. I mean, who in their mind wants to build a wall? But anyway, tell me what else, specifically Brasilia to the United States. What do you think are the major difference in the mindset of the average dentist and dental patient market in Brazil versus the United States? I mean, Brazil and the United States are the two huge markets over here.
Well, that's a good question. Well, I'm actually going to Sao Paulo in 2 weeks, and it will be the first ever Myofunctional Orthodontic Summit there. I think it's the 27th to the 30th of October, if anyone wants to look it up.
Sao Paulo or Rio?
Sao Paulo.
Sao Paulo.
Yep. Yeah. So the difference is, first of all, the government, it's at the government level in Brazil where they're promoting breastfeeding, for example. And I know Derek's been on your podcast, Derek Mahoney, and he spoke about the link between breastfeeding or lack of breastfeeding and malocclusion, because the way the muscles work in breastfeeding versus bottle feeding is extremely different. With with breastfeeding, the tongue has to compress the areola against the palate, and that stimulates maxillary development and stimulates proper tongue function. With a bottle, the tongue can remain flaccid, the fluid just goes in, and the tongue actually has to thrust to stop the flow of milk, and the muscles of facial expression get recruited a lot more, so it's completely different. And Brazil at government level knows this. There's also graduate programs in myofunctional therapy in Brazil. They're very conscious about it. Now, everywhere else where I lecture around the world, I have to spend a good half a day talking about the basic concepts of muscles affecting the craniofacial complex. In Brazil, I can go right into it. It's just in the consciousness over there.
You know,
But the same is true in continental.
and then that child, I mean, it's just so, you know, everybody wants to talk about treating ortho and myofunctional, and they want to treat all. I always want to go back to the prevention. I mean, I don't want to talk about how to fix a cavity. I want to prevent it. And you just see in America, if you go to a movie and Arnold Schwarzenegger kills 100 people with an M16 assault weapon, it's a family film. But if someone whips out a mammary gland, it's rated R, and everybody runs from the theater. And these women are afraid to nurse in public, so then they quit nursing. They go to a bottle, and then that kid's not even, he's not even one, and they switch to a sippy cup. And I think that this is the biggest thing. And then the other thing I notice, you know, I'm always listening to the market, and so many mothers, they say, well, I quit breastfeeding because he was struggling. He was having a hard time nursing. I'm just like, oh my God, that's what the baby's supposed to be doing. They're supposed to be struggling and using their muscles and developing their face. And the minute it just looks like it's not as flowing as a bottle or a sippy cup, they switch right to the bottle. There needs to be huge public relations campaigns on that. And I also think, going back 400 years ago, how long do you think that average baby nursed 400 years ago?
Interesting. Well, look, I mean, the recommendations now, well, out of Brazil, they're recommending at least 6 months. We recommend at least 12 months. I think they were nursing up to 3 years or more. Now, I don't often admit this in public, Howard, but you know, I'm on Dentistry Uncensored here, so I was breastfed for 3 years myself.
How long?
And 3 years. 3 years. 3 years, just over 3 years as well. So, you know, I've got some mummy issues, but at least I got a decent maxilla, just like you know. I think breastfeeding is very important, not only for facial development, but also for emotional development as well, in a young kid. Yeah,
and I was from the generation where America, you want to sum up America in one word, money's the answer, what's the question? I was from the generation where all the mothers were convinced that the formula was better for the baby. So everybody thought, well, if you gave somebody else money, it'd be better for your baby than if you gave them the all-natural stuff. I want to go...
That's interesting.
I want to go to a completely different question, a completely different topic, and a completely different controversy. A lot of the dentists that are listening right now are 30 and under. I mean, that's the major podcast market. It's millennials. You don't have a bunch of 54-year-olds like me listening to podcasts. None of my friends my age, even if I put a gun to their head and said, find my podcast on your iPhone, I'd have to shoot every one of them. But they're getting a lot of conflicting information about tonsils, adenoids. You're talking about this kid developing face, breathing. Some doctors just won't do it ever. Some doctors want to, but anyway, what is your thoughts on tonsils and adenoids? You're seeing a lot of these kids. About what age are you starting to see these kids?
Well, look, we see kids as, we're seeing people mothers bringing in their babies, 6-month-old babies in for a consultation. Obviously, we can't intervene that young. If we could jam one of these appliances in that young, we would, but we can't, unfortunately.
Keep nursing. That'd be the best intervention.
Yeah, exactly. That's exactly the advice we give them. Part of our app, we have nutritional advice on our app as well. So we get it into their consciousness.
What's your app called on the iTunes?
Myobrace. It's called Myobrace Activities, but it's only open to Myobrace members. But so you have to be a Myobrace member to access it. Okay,
so you got to go to myobrace.com.
Myobrace.com.
Myobrace, where do you find that? Myobrace.com?
But if you go to myobraceactivities.com, you'll see some info about the app, etc. So it can be downloaded from myobraceactivities.com.
Okay, so tonsils and adenoids. She's, you got a 25-year-old dentist. She's looking down the mouth of this kid, and she's like, "Whoa."
Yeah. So look, we've had a prominent ENT professor join our lecturing team in the last few years. So I guess we know a little bit about it now, and there's a lot of controversy, as you can imagine, in the ENT field as to when or how to intervene with enlarged tonsils and adenoids. And I'm sure you've heard that some people say it's normal to have enlarged adenoidal tissue that will go away after around 12 years of age or reduce in size. But what happens during that time when 90% of the facial skeleton has been formed up to the age of 12? Are we prepared to settle for a compromised craniofacial complex? I don't think so. Now, especially in America and Australia, especially in America, I mean, you guys, your surgeons have their results published online, right? So I think that has meant a lot of surgeons very reluctant to intervene with tonsils and adenoids. And it's very old school now to think that you need 5 bouts of tonsillitis to warrant a tonsillectomy. Because 80% of kids or 80% of patients who have upper airway obstruction from enlarged tonsils and adenoids have never had tonsillitis in their lives. So we've got to move away from just tonsils being the indication for a tonsillitis being an indication for a tonsillectomy. It has to be about airway obstruction and sleep disordered breathing. So what's my advice? Analyze the size of the tonsils. It's very easy to check. There's a grading system up to 4. You can just look online how to grade tonsils, but it's more important to vet a good ENT specialist who you work with, because not all ENT specialists, just like dentists or orthodontists, will be au fait with how mouth breathing affects the craniofacial complex.
Some people say they are telling the parent that one of the reasons you want to do early interception treatment on a young kid under 12 is that it'll reduce the chance that you might need orthodontics when you're older. What do you think of that advice, or what do you think of that thought concept?
So, I mean, traditionally with early intervention techniques where you're just using, say, a twin block, where you're using a removable appliance, where you're using an RME, I don't think that's true. I think that you pretty much will always need a phase 2. What happens in our practices? Well, we tend to have a better success rate. Now, we use braces quite regularly in our practices as well. We have a range of Myobraces specifically designed for braces. So, I mean, we have no beef against braces. I mean, it actually makes us more money if all of our practitioners went out and did braces as a phase 2, because we could sell another appliance range. But what we're finding clinically is we only have about 5 to 10% of our patients in braces currently. So we manage to get away without it in most cases. Now, we don't care. We don't mind putting the braces on, but we manage to get away without it in most cases.
Talk about the orthodontist from Australia who put really so much of this thinking on the front burner. He was doing research on Aborigines. And do you remember some of the what's that?
Do you mean Begg?
Yeah. Is it B-E-G-G?
In the 50s?
B-E-G-G?
Yes, Begg.
Yeah. Can you summarize
Begg
any of that
is
work? What's that?
Sure. Well, look, he's actually now an embarrassment to the Australian orthodontic community. So he basically went to the Aboriginal communities. He found that they had, for those of you who don't know what Aboriginals are, they're the indigenous population in Australia. And he found they had great arches, less than 2% malocclusion, room for the wisdom teeth, edge-to-edge occlusions, spacing between the teeth. And he said that it was the interproximal wear, the interstitial wear from their gritty diets that caused their teeth to thin out, which reduced crowding in the long term. So that was his rationale to say that degree of wear amounted to a premolar's width in each half of the arch. So that was his rationale for extractions. Now, you guys in America have a great anthropologist called Corricini, and he published in 1990. He actually went through Begg's old research and found that Begg doctored his own results. He was a fraud. Begg's own results showed that as patients aged, as they got older, crowding actually increased. Now, you'd assume, if his theory were true, as they got older, there would be more interproximal wear, and therefore crowding would reduce. So Begg's theory has been roundly refuted, but some people around the world are still using that theory as their rationale for premolar extractions, and it shouldn't be used.
So did he, what year is, what year did he pass away?
I don't know, but he published in the 1950s, so he's long dead now. His theory and his body.
So another concept he said was actually was pro sealants. He said that the grit in their diet, that they actually had no more pit and fissures by the time they were 17. So there was so much grit in the diet, the interproximal wear lost a bicuspid in each quadrant, so the wisdom teeth could slide in, and there was no occlusal cavities because all the pit and fissures were down. Was that part true, or were both parts false?
Look, it makes sense from an occlusal perspective. It doesn't make much sense from an interproximal perspective, in my opinion.
Right,
so
exactly.
Absolutely, hard fibrous diets result in occlusal wear, no doubt about it. And that's why they could have edge-to-edge occlusions. Nowadays, with our soft diets, cusps and prominent cusps are a reality. So we can't really finish to an edge-to-edge occlusion.
So he passed away before he was an embarrassment to his profession, right?
Lucky him.
Yeah, I've been honored by, I was alive when I was an embarrassment, so I got to see that I became an embarrassment to the profession. So what was it? What was his name? PR Beg, or?
I think that's right. PR Beg. I can't remember exactly. I think it is.
I wonder what the P and the R stood for.
I thought it was Raymond Beg. Raymond Beg. Is that right?
Was it Raymond Beg?
That name.
Okay. Oh, the R was Raymond. PR Beg.
Yeah.
Raymond Beg.
Yeah.
That is amazing. Yeah. So do you see any? Are you ever treat any indigenous population peoples, Aborigines, or that you see any myofunctional differences because of their diet or culture?
There's a few, but as all the research shows, on adoption of a westernized diet, the malocclusion rates are just as bad as the rest of the population. So it doesn't matter really where your genetics have come from, even within one generation. There are a lot of studies done in the UK. Chinese immigrants, this was published in the 80s, Chinese immigrants, their parents had great occlusions. Their offspring, as soon as they started eating the Maccas, and Maccas is our abbreviation for McDonald's, by the way, or you guys say Mickey D's over here. Maccas.
Say it again?
Maccas.
Mackers? Like M-A-C-K-A-R?
Yeah, you're nearly there. You got to work on that Aussie twang a bit more, mate. Maccas.
Mackers.
So as soon as they adopt a westernized diet, you see malocclusions just as bad. So that's what we're seeing these days.
You know, another thing about that diet, I mean, there's pros and cons to everything. The one thing you see in the United States a lot is the first generation immigrants that came from a very poor country. It seems like the mom's always 5 foot tall and the dad's always, 5'5", 5'6", 5'7", and all their kids are a head taller than them. And then I was reading a study that in China, that the average Chinese man that lives within a seafood supply of the coast, so all along the coast where they're eating so much seafood, is something like almost 5'9", whereas by the time you go 1,000 miles inland, it's 5'7". There's almost a 2-inch difference in height just by having access to eating out of the ocean.
Yeah, wow. That's very interesting, yeah.
I did, yeah. So really, am I going to convince you to put an online course on Dentaltown?
Yeah, for sure, 100%.
I would love to, because I think so many people don't know about this. They don't understand this, and I'm a big fan of yours, and I think it turned on a lot of people. And the other thing is, I don't know how to say this politically correct or incorrect, but it seems like a lot of the people that started in myo research or whatever, I don't know, they just seem on this very conservative country of America, they just seem to be more I don't know how to describe it. Hippies, alternative, holistic.
Yeah.
And it wasn't the delivery to the people. It almost would have had to be delivered by like some 80-year-old man, that's white hair and a cane, at a dental school.
Well, we have a few of those. We definitely have a few. I mean, Dr. Chris Farrell is, he'd be a bit cross if I told you he was approaching 80. He's not quite there yet, but he's close. So, I mean, look, the funny thing is, I mean, you're saying yes, in America we have that stigma attached to us. So it's not so much these days, especially. I've got the quote here. I mean, I was on the American Association of Orthodontics website this morning, and there's this video on frenectomies, and they say, I've got the quote here. They're saying, If left untreated, restricted tongue function can cause adverse changes in tooth position and jaw development. Balanced soft tissue environment helps us maintain changes in tooth position and jaw development long term. So look, the AEO, I mean, for a long time, for years, they've been talking about mouth breathing, and now they're talking about the effect of muscles. The knowledge is there. There's just been debate as to how we can practically implement a system that treats it. And look, around the world, it is becoming the treatment system of choice. We're in government health systems now. In China, Russia, and Sweden, we're in government health systems. Next year, I'm going back to, do you know where Sri Lanka is, Howard?
Sure, south of India, little island, 22 million people.
That's it. Yeah, very good. Wow.
Well, they have a Dental Town study club there where like 50 of them meet and they watch a Dental Town online CE course. I think it was so cute of them because they asked, they said, is it okay if we just buy one course for $18 and all 50 of us watch them? And I said, not only is that so romantic, you don't even have to pay. I just gave them.
That's awesome.
So it's a Dental Town study club, and they meet once a month, and that's their study club. And the lecture is an online CE course from Dental Town. And but anyway, back to Sri Lanka. What were you saying?
That's right. Yes. So my parents are from Sri Lanka, and about 3 years ago, I was invited by the health minister to come and talk about what we do there. And the health minister said, you know, yes, look, this is great. Let's implement this nationwide. And then, you know how many orthodontists service 22 million people in Sri Lanka? Have a guess. How many orthodontists are in the country?
I would hope there's at least 100.
There's about 20 odd. About 20 odd. So there's only about 20 servicing 22 million people. We talked to the orthodontists. We got in that country and we got opposition from them. And I guess what annoyed me a little bit about that was we went to one particular orthodontist. I would name him if I could remember his name because I'm that livid about it. But he told us the reason why we're not backing this is because it's too easy for general dentists to use. The system is too easy to pick up and run with it. And they have just over 1 million patients per practitioners to choose from. And, you know, this is about kids' health. I mean, it's not about just straightening teeth. It's about bettering the health of these kids from a sleep apnea perspective. And so I guess those sorts of stories which I've encountered around the world, they keep driving me. And they keep driving this move. We don't believe we're part of a business or a company here. We believe we're part of a movement to make these kids' health better.
I mean, mission and purpose is so much more gratifying than money. My favorite, growing up at a Catholic school and going to Catholic Mass every day, my favorite Catholic lady was Mother Teresa Calcutta. And my favorite line from Mother Teresa Calcutta, some Western journalist was watching her clean maggots out of some sick man's skin, and he said to Mother Teresa, I wouldn't do that for $1 million. And she said, either would I. Hey, I want to go to the next deal. So, okay, so you're doing early intervention, you're doing myofunctional research. I've been a dentist for 29 years, and about 5 years ago, obstructive sleep apnea just exploded. I mean, you know, it was never mentioned when I was in school. It was never mentioned 10 years out. I mean, it seemed to almost came out of nowhere. So my question is myofunctional intervention, do you think that will prevent more obstructive sleep apnea? What are your thoughts on obstructive sleep apnea? How much of it is fad? How much of it is real?
So I don't think it's only preventative of it. I think it's also therapeutic of it as well. Now, I think, so did you weren't diagnosed with sleep apnea yourself, were you, Howard? Or
no, I did the sleep study because I just assumed I'd have it. I mean, I just assumed I did. The guy told me the next morning that he only saw someone sleep as deep as me about every 3 months. So I don't have it.
That's great. That's good. Okay. Well, look, the first thing is
he told me that I don't have sleep apnea, but I'm still old, fat, short, and bald.
Oh, that's a shame.
Yeah, but he said at least
the Myobrace can
apnea.
fix a lot of things. Unfortunately, it can't fix that, I'm sorry to say. Maybe our next range. Look, the first thing with sleep apnea, as you know, the first line of treatment is a CPAP machine. Problem with CPAP is, first of all, it's like headgear. Now, I've seen 2-year-olds on CPAP machines, and it has to be strapped so tightly because the air can't escape, and it actually holds back mid-facial development. Some of them have kind of a chin cup to hold back mandibular development. Now, it's not just hearsay, it's not just anecdotal to say that it affects craniofacial development. There is research to say, I mean, there's a research paper I came across saying that class 3 malocclusions were generated with not even long-term CPAP use, with medium-term CPAP use by holding back the mid-facial development. You'd think it's only in kids as well, but it's also in adults. There was a study done out of Japan, 46 subjects, published in chest journals, so nothing to do with dentistry or orthodontics, and it found that all subjects within 2 years of using CPAP had deficient maxilla, so the maxilla was actually protruded by using CPAP, and it reduced the discrepancy between the maxilla and the mandible, not because the mandible came forwards, but because the maxilla was tipped back. And that's exactly the opposite of what we want to achieve in sleep apnea treatment. So CPAP, yes, it has saved a lot of lives around the world, but long-term, even medium-term, it's making the problem worse, especially in kids. We need to look for something else. So, look, we've used mandibular advancement devices as well, and nowadays the research is showing that MADs to bring the mandible forwards can be just as effective as CPAP. But how effective is CPAP? Well, not very effective. And the research shows that about 40 to 55% of MAD cases are unsuccessful. Why is that? Well, I think the problem we've had with sleep apnea treatment, it's the same problem we've had with orthodontic treatment, same problem we've had with TMD treatment. We've been too concerned with the mechanical, not concerned enough with the biological. Now, when you're using a MAD to bring the mandible forwards, yes, that's fine. Yes, you can make the patency of the airway increase, but you're not doing anything for the functioning of the airway. And the airway is a dynamic muscular organ whose dimensions and shape changes not only by the second, but also by the millisecond. So I kind of laugh now when sleep dentists are using very specific millimeter specific titrations to treat sleep apnea, when the airway can collapse regardless of how many millimeters you've put into your sleep apnea appliance. So in terms of treating sleep apnea, the research is now showing that slowing down the breathing is extremely important in preventing airway collapse. It's called Bernoulli's principle. Have you heard of Bernoulli's principle before?
No.
So it's basically if you breathe too fast, it's like a straw collapsing. If you breathe too hard and fast, negative pressure gets generated inside the oropharynx, and the oropharynx is a part of the airway that's unsupported by bone or cartilage. And it's like when you drink too hard through a paper straw, negative pressure gets generated inside, atmospheric pressure rushes in to collapse the straw, and that's what happens to the airway. So you need to slow the rate of breathing down, and that's what we do with our treatment. Also, there's a big relationship between the genioglossus muscles. So the genioglossus muscles, it's a paired muscle in the tongue, the largest muscles in the blade of the tongue, and it's been shown that the genioglossus is actually physically attached to the connective tissue above the hyoid bone. So what they're doing is just by training the tongue, you're making the airway less susceptible to collapse and actually increasing airway patency. Now, where's the research on that? Well, a meta-analysis was published about 2 years ago, 2014. Admittedly, there were only 9 studies in the meta-analysis, but increasingly now, myofunctional treatments are being shown to be not only preventative, but therapeutic of sleep apnea. And I think that's the most important work we do, not threatening teeth.
So you talked about the orthodontist in Sri Lanka that didn't care for this. There's almost 11,000 orthodontists in the United States. What are their views on everything you're doing?
Look, initially they were extremely resistant, and Dr. Farran, when he first introduced it a few years ago into the US, was kind of hit over the head a bit, as he was in most countries around the world. But now, as I said, I mean, Americans have that pragmatism. As soon as they see the evidence, the change, I mean, there's been a complete change in the flavor of the orthodontic community now. Everyone, I think it's been pushed by the general public. Everyone wants to intervene earlier. Everyone wants to try and avoid extractions if possible. Everyone wants to try and avoid braces if possible. We've seen a huge increase.
One big disconnect I see with dentists is the dentists all seem to be older baby boomers, and the large portion of the market is millennials, and the older dentists, they hate words like alternative or holistic or natural. But the dentists I know that have those words on their website, even if it's just marketing, they change nothing, it's really effective. And I would just think, knowing the millennial market, especially when it comes to their babies, that they would do anything to prevent ortho or prevent disease. And it seems to me that if the office had a course on the advantages of nursing the baby for 1 to 3 years, or more course diet, or anything, the millennials just seem to be so into prevention. And the bottom line is that the dentists that are so conservative, when you talk to them, they don't like the U.S. healthcare system. I mean, they're actually naturalistic. If a dentist gets high cholesterol, he doesn't want to take a statin. If a dentist has high blood pressure, he doesn't want to take a high blood pressure. I mean, so they totally, when you talk to them, they totally reject the go to the doctor and get on a pill. They totally reject that. And then when someone comes to them and says, well, I want alternative dentistry, then they go apeshit. But they're all holistic. The ones I know, they all want to treat their cholesterol, all their health problems naturally with diet and exercise and clean living.
Well, that's interesting. Look, another thing we get in courses is they ask us, can you actually make money out of this? I mean, you throw braces on, it's easy, kick them out the door. You can take 4 teeth out, it makes it even quicker sometimes. And look, the answer is yes. I mean, look, as we know, parents, the joke is orthodontics is recession-proof. Pediatrics and orthodontics is recession-proof because parents put their own health aside, put their own finances aside to make their kids' teeth straight. How much do you think parents will pay for better health in their kids? That's why our practitioners always charge more than the traditional orthodontic approach. We always tell them, bring around your local community, check how much the going rate for traditional orthodontics is, and charge at least $1,000 on top of that because we're doing so much more. Yes, we're getting the straight teeth, and yes, you can offer braces as part of it, like we do, but it's important to go beyond.
Last question. I can't believe it's already an hour. Last question is this. You have talked about many countries. Some of the, like America is a very insurance-driven industry by private insurance. Singapore doesn't have insurance. Tokyo, London, and Paris all have government dental insurance. You're in Australia. Explain the Australian dental insurance. Is it private? Is it government? And what effect do you think that has on what you're trying to do versus in Brazil, where you're huge in Brazil and they don't have really an insurance market?
Sure. To be honest, financially for our company, it has zero effect. For example, I mean, here in Australia, nothing is really covered by the government. There are some severe orthodontic cases if you go through the public system that can be covered. It's unlike medical treatment here, which is basically fully covered by the public health system. Dentistry and orthodontics is basically not. So it's fully private here, and parents are willing to pay out of pocket regardless of whether or not their private health insurance covers it. So we don't really have much of a conversation about their private health insurance. The culture here in Australia is, okay, look, a lot of private health insurance does cover most of it, but a lot of patients here still don't have private health insurance, but they're fine. They just say, look, that's reality, we'll pay for it. In places where there's universal dental or orthodontic care, I really haven't seen too many places around the world where there's universal orthodontic care. But we do have, even in Australia, at local level here in community health dental centres, we're having some practitioners using the Myobrace system, not as an orthodontic device, but for better craniofascial development. Pediatric dentists using it for better craniofascial development as a preventative measure for sleep apnea. So I think what we're going to see in the next 3 to 5 years is an increase in the amount of ENTs, sleep physicians, etc., using the system to prevent the onset of sleep apnea and SDB in the public systems.
You're an amazing man. So I'm Howard at dentaltown.com, but the guy in charge of the online CE is Howard Goldstein. So he's Hogo, Hogo at dentaltown.com. So to the listeners listening to you, when do you think they could log on to Dentaltown and see a clinical online CE teaser course of what you're doing?
Yeah, well, I'll try and get that sorted in the next 2 weeks before I leave for my next trip, Howard. Yeah, let's do that.
Oh, man, that'd be awesome. And how do my homies contact you? What if they have a question? You want them to go to myoresearch.com? Myoresearch.com is a website,
and there's email addresses there. If they've got any questions clinically, they can do that.
What's your email?
They can hit me up on Facebook personally. So on Facebook, Rohan Wijey, hit me up, personal message me.
Rohan Wijey, Wijey. Okay, well, hey, again, I called you. You didn't call me. I'm a big fan of your work. It's amazing. I mean, you're just always around 5 continents. How come you've never given a course on Antarctica? Or you just hate penguins?
I've flown over Antarctica. On the way back from Buenos Aires once, I've flown over. That's the closest I've got. But maybe someday. That would be cool, wouldn't it?
You got to treat those penguins. They need dentists too.
Okay. Everyone does. Everyone needs a Myobrace.
Okay, well, seriously, thank you so much for spending an hour with me and my homies today. I'm sure they enjoyed it. And if you're listening to this stuff, myofunctional research, you got to learn more about it. It's more preventative. It's more holistic. It's more natural. Millennials love it. This is the future. The future's here today. Learn more about it. Rohan, thank you so much for spending an hour with me today.
Cheers. Thanks, Howard. The honor was mine. Thanks very much.
Well, actually, you spent an hour with me today, but you spent an hour tomorrow with me today. So we should call this podcast
that's right.
Tomorrow Today. This is Tomorrow Today with Rohan Wijey. By the way, one last thing. My brother left America 2 years ago and moved to Sydney. And my God, he's not coming back. I've flown down with my boys a few times. And
well, I was born in Sydney, and I'm in Sydney every few weeks. So next time you're in Sydney, hit me up and we'll go party.
I want to. And you know what? I've been in 4 continents in the last 4 months. Sydney is the only place where when you get on the plane, you're like, okay, why am I leaving? I mean, why am I leaving this to go back to Phoenix? I mean,
have you been up to the Gold Coast?
Oh, yeah, Brisbane, Gold Coast. Yeah. That's a little dangerous, though. You know, I shouldn't say anything controversial about that, but my God, I was there at Gold Coast at some resort, and they almost lost a Japanese swimmer. A riptide carried him out like, hundreds of yards, and people were screaming, and they ran for a boat. But anyway, they were warning us. They were warning all these people that weren't from the Gold Coast. They said, you don't get it. This isn't a beach in Florida. There's a riptides, and some Japanese man almost took his last swim out there.
That's right. And we got sharks, and if the sharks don't get you, the people will get you. It's dangerous here in Australia.
Why are the riptides so much stronger there than in California or Florida?
I'm the wrong person to ask. I'm not sure. I don't know. Yeah, I don't think many Americans would survive out here. You need to be a tough Aussie to survive out here.
All right. Well, on that note,
I mean, shoulder pads helmets with your football, don't you? I mean, we don't have any of those shoulder pads and helmets.
I don't know if there was a storm out there or whatever, but I'll never forget because when I was at Gold Coast, I was on like the 10th floor of some hotel overlooking the ocean, and when those waves come in, I mean, it was a thump. 10 floors up, I had my sliding glass doors open, and I'm laying in that bed, and I mean, you could hear each one of those waves crash, thump on the ground. Maybe there's a big storm out there. I don't know, but man, it was just gorgeous.
Possibly.
It's got to be the most beautiful area in the world. All right, next time I see my brother Paul, I will definitely look you up.
Awesome. Sounds good, Howard. It's a pleasure.
All right, buddy. Take care.